So I'm going to discuss a little bit in terms of conventional thinking and some of the new thoughts when it comes to intravascular imaging and physiology. I'd like to start off by talking about intermediate lesions. The DEFER, FAME1, FAME2, DEFINE FLAIR, and IFR Sweetheart studies established intracoronary physiology as the technique of choice in deciding whether or not to treat a non-left main lesion. We've tried for years using IVUS or OCT to come up with numbers that approximate physiology. And we failed because the numbers are all over the place and the statistics are not terribly impressive. But then come along two studies, FORZA and FLAVOR. FORZA was a randomized trial of FFR versus OCT to guide management of intermediate lesions. And there were stent implantation criteria. Why is this doing this? There were stent implantation criteria and stent optimization criteria for both FFR and OCT, and the outcomes at 1 year follow-up were essentially identical. In fact, they favored OCT guidance in deciding whether or not to treat a non-left main lesion. Now, when it comes to FLAVOR, which was recently published in the New England Journal of Medicine, again, it was a randomized trial of FFR versus IVUS. I don't know why that's doing this. There were criteria for deciding whether or not to treat. There were criteria to optimize stents based upon FFR and IVUS. And now, all of a sudden, the outcomes at 1 year are identical with the two groups. So we now have two randomized trials that say that imaging is as good as physiology. My takeaway is that if you optimize the PCI with IVUS or OCT guidance, you can use IVUS or OCT to assess intermediate non-left main lesions. The only downside is that you implant more stents, but the patients do equally well. So all of a sudden we can challenge successfully the dominance of physiology to decide whether or not to treat a non-left main lesion. Now, the field of physiology is actually moving, interestingly, to virtual FFR, whether it's virtual FFR based upon angiography or IVUS or OCT. So we developed a model of IVUS-derived FFR based upon the prospect data. And we applied it to the prospect patients, and you can see that if the IVUS-derived FFR is less than 0.95, the patients do much worse. And then if we integrate the IVUS FFR with the known prospect criteria of a lumen less than 4, a plaque burden more than 70%, and a TICVA, it supplants them. So all of a sudden, we have a TICVA, a plaque burden more than 70%, and an FFR, an IVUS-derived FFR of less than 0.95 are dominant in determining whether or not the patient has an event at follow-up. And that's not the only outcome study. This is an OCT-derived FFR study in patients with acute coronary syndrome, and OCT-derived FFR performed after stent implantation was associated with a better outcome than an OCT FFR greater than 0.9 was associated with a better outcome compared to an OCT FFR of less than 0.9. So all of a sudden we have outcomes data related to virtual FFR based upon intracoronary imaging. What about left main disease? We've been using FFR or IVUS depending on your preference, but now we have non-hyperemic pressure ratios. And this is a study of IFR, FFR, and IVUS. And it turns out there's a disagreement between IFR and FFR of about 20%. And if anything, IVUS agrees more with FFR and disagrees significantly with IFR. So it is entirely possible that IFR should not be used to decide whether or not to treat a left main lesion. The other left main study that we performed and published recently has to do with patients with subclinical left main disease. So we took patients who had minimal left main disease angiographically, a preserved lumen by IVUS, and we measured their plaque burden. And you can see that the plaque burden averaged 40%, the lumen area averaged 13 square millimeters, the angiographic diameter stenosis averaged 12%. So these were minimal left main disease, and we're talking about over 3,000 patients. We linked these to the national database, the US database. There's a death index, and these are the predictors of mortality beyond 5 years in these patients. And you can see that we have the typical clinical predictors, but there's also a plaque burden that's predictor, while the lumen area was not in these patients with subclinical left main disease. And so when you look at all-cause mortality, which is the best marker in the death index, you can see that when you divide patients by quartiles of plaque burden out to 12 years, if you're in the upper quartile plaque burden, remember the lumen areas are preserved in these patients, your mortality at 12 years is almost 50% based solely on subclinical plaque burden in the left main. Now, we also looked at cardiac death, which is not quite as reliable in the death index. And if you're the upper quartile of left main plaque burden, the 12-year mortality is about 25%. So this is really powerful data, and what the editorial that was accompanied this article in JACC Intervention said, sometimes what you don't see can cause you harm at long-term follow-up. So we concluded in a large consecutive cohort of patients who underwent coronary angiography and IVUS imaging of the left main and who were treated conservatively without intended revascularization, increasing left main plaque burden, but not MLA or angiographic diameter stenosis, was independently associated with long-term all-cause and cardiac mortality. The next topic I want to talk about is acute coronary syndrome, or the lesions that cause acute coronary syndrome. We know from histology that the number one cause is a plaque rupture, but I'd like to talk about calcified nodules, because calcified nodules are becoming the bane of many of our existence. This is data presented at TCT this year from a study in Japan called the Tactics Registry, and they looked at the event rates after treating plaque erosions, plaque rupture, and calcified nodules. And you can see that if a patient presents with a calcified nodule that's stented, their 1-year cumulative rate of MACE is 30%, much higher than plaque rupture and plaque erosion, with plaque erosion doing the best. Now, the pathologists divide these calcified nodules into two types. They call nodular calcium, which is no thrombus and an intact fibrous cap, and calcified nodule, which probably should be called an eruptive calcified nodule, is associated with disruption of the endothelium and overlying platelet and fibrin thrombus. The CLIMA study from Italy was a natural history study, and they looked at the LAD calcified nodules, and you can see that a calcified nodule with an eruptive fibrous cap is associated with more events than a calcified nodule with an intact fibrous cap. This is what the pathologists would call nodular calcium. This is what we call an eruptive calcified nodule. Well, they do bad. Again, calcified nodules in patients down with acute coronary syndrome have an event rate at 6 years of about 50%. And when they have recurrence, it's because of recurrence of the calcified nodule within the stent. What do you do about that? We're really not sure how to treat them before we stent them. We're certainly not sure how to treat them after they present with in-stent restenosis. This is one paper from Japan that treated in-stent restenosis secondary to a recurrent calcified nodule, and you can see how badly they did at follow-up, an event rate at 3 years of over 80%. Now, what about stent implantation? We have a huge amount of data. I'm not going to go through anything like this, but I'd like to then focus on some more recent data. So the two largest randomized trials are IVUS XPL and Ultimate. Both showed improved events with IVUS guidance compared to angiographic guidance, and we took the patient-level data from these two studies and created one large database, and we looked at mortality at 3 years of follow-up, and you can see when we combine these, which gives us about 2,500 patients, you can see that the mortality at 3 years of follow-up is half in the IVUS-guided group compared to the angiographic-guided group, and if you achieve the criteria for optimization based upon IVUS, the annual mortality is about 0.2%. We also asked from this database a simple question: what if you do angiographic optimization with post-dilation? Is that as good as IVUS guidance? And the answer is simply not. Now, we have meta-analyses of IVUS versus angiography, but we now have data for OCT versus angiography, and quite frankly, it's probably not as good as the IVUS data, maybe because it's too new. And you can see in these 1, 2, 3, 4, 5 meta-analyses, the events are not so much better with OCT guidance compared to angiographic guidance, and when we compare OCT versus IVUS, the outcomes are about the same. There's one cohort study called the ROC2 cohort study that compared IVUS, angiography, and OCT in distal left and left main bifurcations, and you can see that the IVUS and the OCT groups did as well, much better than the angiographic outcomes group. Now, there's a lot of talk recently, and at this meeting, a lot of talk about post-PCI FFR, and over time, this is a very nice study from Stanford that showed that the higher the FFR after stent implantation, the better the event rate. But this has been actually challenged in a randomized trial called Target FFR. Patients were randomized to a FFR optimization strategy versus a control group, which was an angiographic strategy, and the FFR strategy was very carefully specified, but you can see that at follow-up, there was no difference in the two groups. So at least what randomized trial data we have does not suggest that FFR stent optimization is going to be better than angiographic stent optimization. The last topic I'll talk on very briefly is chronic kidney disease. This is non-imaging data. This is data from ADAPT-DES that divided patients into 4 groups. Those without chronic kidney disease who did not develop contrast-induced nephropathy, those who did develop AKI, patients with chronic kidney disease without AKI, and most importantly, those who present with chronic kidney disease who develop contrast nephropathy. And you can see that the all-cause mortality in the chronic kidney disease, contrast-induced nephropathy is very high. It's 16% at 2 years. And the reason I want to point this out is Ziad Ali, who was here earlier in this meeting, pioneered this concept of zero contrast PCI. But we now have several recent registries that have confirmed it, several of them from India, showing that zero contrast PCI, that is IVUS guidance, is associated with preservation of renal function, and that the patients rarely transition into renal replacement or dialysis, which of course is associated with a very high mortality. So again, thank you. These were just a quick snapshot of some recent studies and some recent data that I think is going to impact in our treatment of our patients in the near term. Thank you very much.